Let's see. All right. Hello, can everyone hear me?
Yes, I think we can hear you, Dr. Talent.
All right, very good. And just wanted to double check and make sure that we have the slides up for the REM sleep behavior disorder here.
Yes, sir. We're good.
All right. Okay, very good. Well, good morning slash close to afternoon, everyone. I think this is your last session, and look forward to talking with you about REM sleep behavior disorder. As you may have heard this morning, I have no associations or affiliation with industry, so there's nothing to disclose. So, REM sleep behavior disorder is a very interesting phenomenon, and you'll definitely encounter that. And as you know, kind of tying in with the some of the discussion you've already heard earlier today, with home sleep testing on the rise, you'll see a higher concentration of things like the parasomnias that you're checking for, like REM sleep behavior disorder, as well as the more complex cardiac patients, for example, in lab. So anyone running sleep studies will definitely want to be very familiar with this, because likely over time it will just represent a higher percentage of that which is referred for in lab testing. So, in terms of the characteristics of REM sleep behavior disorder, it is primarily manifest by excessive nighttime motor behaviors. Okay, now it's not all motor behaviors, and we'll talk more about that, kind of nailing that down and helping to differentiate between RBD and other conditions. It's commonly associated with altered dreaming mentation. Oftentimes they have violent content or situations that are uncomfortable to them, where they're trying to escape a situation. And the core of the problem is loss of the normal stage REM muscle atonia that keeps us from acting out our dreams at night. So, and one hallmark is the behaviors are not associated with arousals. So it persists. It's not that you're, say, having a dream and then you wake up and then you move your arms around or anything like that. It's associated with continuity of sleep. In terms of the diagnostic criteria, on the PSG, you're looking for elevated either tonic or phasic muscle tone in either the CHIM or limb leads during stage REM specifically. And I'll show you some examples here in a few minutes. And you see either a history of abnormal REM, stage REM behaviors during the PSG, or they report, or bed partners report, a history of disruptive sleep behaviors, or sometimes even injurious behaviors where they, punch or kick or fight, those sort of situations.
Talent. It looks
Yes.
like slides are not keeping up with you again.
Okay. Let me see here.
Something, I don't know.
What are you seeing right now? Are you seeing the title page or?
The title page.
Okay. It seems to work better when I actually don't go into the actual formal slide. How about now?
It says REM sleep behavior disorder. So those changed very quickly. So that was fine.
Okay. Yeah, I guess we'll just use this screen. For some reason, when I try to do the full screen for you, it doesn't seem to want to advance. So we'll just use, is it still large enough that everyone can see this?
I believe so.
Okay, very good. We'll just use this. For some reason, this seems to advance much better than the actual formal presentation that's full screen. So we'll go with this. And so additional diagnostic criteria include the absence of EEG epileptiform activity during stage REM sleep, which usually stage REM sleep is one of the stages of sleep that you see the least amount of epileptiform activity anyway. You see much more of the epileptiform discharges in non-REM sleep. But regardless, you still possibly can, so you just want to make sure that that's ruled out as well. It has a decided male predominance, almost 8-1 over the prevalence in females. The mean age of onset is somewhere between 50 to 65. And it's an estimated 60% of cases that are idiopathic. And here in just a few slides, we'll talk more about idiopathic REM sleep behavior disorder versus secondary. And one majorly significant aspect of REM sleep behavior disorder is it can be a harbinger of other diseases to come, in particular neurodegenerative diseases, and we'll definitely talk about that here in a slide or two, and which diseases in particular, but by far the main one being the Parkinsonian family of diseases. And that can be quite a bit of time later. There was a recent study, large study with an N of 1,280 patients, followed over 12 years, and about 3/4 of them developed a neurodegenerative disease over that time frame. Worldwide, there's a very significant number of people affected, up to 75 million. It's about 1% of the population, which interestingly, Parkinson's disease is also about 1% of the population. Now, it's not a direct, one-to-one correlation between Parkinson's and RBD, but as you'll see, it is quite common. And when you break that number down, it's up to 5% of older adults. Older studies, I included these two down at the bottom, the one from 1997 and the one from 2000, just to show you that our awareness and detection of this is increasing. These were much older studies, not great in terms of design, one being a telephone survey, and it was estimating the prevalence at anywhere from well less than 0.1% to 0.5%, but clearly it is far more prevalent than that with increased attention and detection. In terms of the pathogenesis, the pathways involved, it can be different routes that you get there in terms of developing REM sleep behavior disorder, but in general, the involved areas include the brainstem area, so the pons, and in particular the locus coeruleus and areas around the locus coeruleus and the subcoeruleus nucleus. And what happens is with diseases like Parkinson's disease and dementia with Lewy bodies, you get proteins deposited that interrupt normal neuronal pathways, and that can lead to this release of the inhibition of the motor activity during stage REM sleep. So there are certain neurons that turn on during stage REM sleep, in particular, so that we don't act out our dreams. So, if you're walking off of something, you don't, stand up on the bed and step off the side or things like that. And on some of the functional imaging studies, you see decreased activity in many of the same common patterns that you see with early Parkinson's disease. So again, just further establishing that relationship and correlation there. Some of the mimics of RBD, one of the most common, I would say the most common, are apnea termination arousal. So in other words, those people who have the apnea, they get the noradrenaline release, it causes an activation, and then it's essentially kind of like a confusional arousal where they wake up and they're moving around just briefly. It doesn't have to last as long as a frank confusional arousal, but you'll see that motoric activity sometimes with those. Periodic limb movement sometimes will be confused with it. That's why when you're taking a history for RBD or discussing this with a patient, you really have to tease out, so exactly what are you doing? What are you noticing? What's associated with that? And they may just say, no, I kick my legs a lot, especially when I'm going to bed at night, or, those kind of things, which certainly would point toward PLMs. Nocturnal seizures can sometimes mimic it. Usually seizures, however, are more stereotyped. REM sleep behavior disorder actions can be more varied. You may see someone just reaching for things. They can, of course, punch or fight or kick or things like that. But usually seizures are more stereotyped. So it's typically the same type of action repetitively with those over various episodes. Of course, you want to tease out somniloquy or perhaps sleep terrors, especially in children. So, if it's a child, RBD would be decidedly uncommon. Sleep terrors more common, obviously, in comparison. Nightmares, it's a possibility depending upon the individual's reactions. PTSD, of course, can certainly mimic it. And rhythmic movement disorder is another one that's you'll see mentioned in the differential, but also usually pretty easily differentiated, because that's usually repetitive stereotype type actions in children usually, and in individuals who have, in particular, any degree of mental retardation, where they bang their head or rock back and forth in bed, those kind of situations. As I mentioned on the previous slide, this labeled pseudo RBD is the behavioral symptoms in particular severe untreated sleep apnea. So you definitely can see that. And in those individuals, a lot of times you'll see resolution of a lot of those motoric behaviors. That doesn't always mean it's just pseudo RBD, because as you all know, treatment of any underlying sleep apnea that was previously not treated definitely helps decrease the incidence of really most, if not all, parasomnia behaviors. So, if you're treating obstructive sleep apnea, you're less apt to act out dreams in RBD and all the other parasomnias. So, just reinforcing the importance of treating obstructive sleep apnea whenever you see that. So some specifics about the kinds of actions you see with RBD episodes. Frequently, it is violent. It can have a lot of associated emotional content. Part of this, of course, is because obviously we're going to notice that more. If you're in bed asleep next to someone and they're dreaming that they're reaching out and, maybe letting, I don't know, a bird sit on their finger or something like that, then that's just going to be an outstretched arm and finger. So it's probably not going to wake you up. Whereas if they're dreaming that they're fighting off an attacker, obviously that's much more likely to wake you up and come to your attention. So, so it can be quite violent, even though it can be aggressive. That's less common in terms of being directed toward bed partners, but you definitely see that. You can. The most common thing being, just kind of, I call it a punch to the back or the arm, during the middle of the night. So, further reinforcing why it's so important to make sure that you remove any potential weapons from the bedroom with RBD, and tell them about that and say, anything that could be weaponized, for example, a heavy lamp on a nightstand, things like that, and certainly any true weapons that could potentially be stored in the bedroom are definitely not a good idea in this situation. Typically, these are not appetitive, so they don't tend to, meaning circumstances for which humankind has an appetite, such as the feeding urge and so forth. Even though you may see people doing things like, kind of mimicking bringing something to their mouth or something like that, for example, like they were using a utensil. You can see that, but if they're actually getting up and going and eating and things like that, it's usually more like those sleep-related eating disorders related to sedative hypnotic use sometimes, or potentially nocturnal eating syndrome, even though there's a difference there in terms of awareness on the individual that's affected. But individuals, for some reason, commonly say that they're fighting off either an animal or an attacker. It goes above and beyond just the normal frequency of having any kind of dream like that. So there's something about it that has a proclivity to include those kind of threatening situations. It's not just that those are the only times you notice it. So, it's kind of a combination of both factors. But it can be, directed toward a bed partner where they actually start struggling or fighting with them. I know I had one man who thought he was subduing an alligator and keeping it away from his wife, when in actuality he actually had his wife's leg and was holding it down when she awakened, and of course got him to stop. So the stories can be quite interesting. Here's a PSG example of normal stage REM atonia, of course, as everyone's familiar. This is the chin EMG and the leg EMG here. So you can see the nice, normal, suppressed background on that. And then here's an example of stage REM without atonia. So this is the neurophysiologic correlate of REM sleep behavior disorder. So you can see, even though your chin EMG up top, the third line down, is nice and suppressed, look down here in your legs. See, clearly that's excessive motoric behavior during stage REM sleep. And this individual did have the behavioral correlate. But it just goes to show you don't have to have both. It can be either or. So I mentioned the difference between idiopathic REM behavior disorder and symptomatic. So idiopathic, there's a movement to kind of label it more the cryptogenic, just because there's more and more evidence, obviously, to suggest that it's not truly idiopathic. It's just an early manifestation of another disease. But anyway, at that stage, at least, that's not known. So there's no underlying disorder. Perhaps over time, with increased detection of and earlier identifiers of neurodegenerative diseases, then we may be able to significantly determine what lies ahead. Of course, that raises a whole other series of questions about, do people want to know if in 15 years they're going to have Parkinson's disease or dementia with Lewy bodies? It depends. That's the subject of another debate and discussion. So there's that. And then there's also the symptomatic or secondary versions, where there is already an underlying known primary disorder. So you see on this page a lot of associations listed. However, in clinical practice, you don't see a lot of these, but these are all reported. By far, the vast majority are the synucleinopathies, so Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy. Okay, so the core problem with each of these conditions is alpha-synuclein is deposited abnormally and leads to the neurological process. We'll also talk a little bit more about narcolepsy, medications that can cause that, primarily the antidepressants, but we'll look at that. Intoxication sometimes of anticholinergic type medications of which the tricyclic antidepressants belong to that group. That's a possibility. I've never seen a case myself, but it can be reported. You do see more periodic limb movements with RBD patients. You can see vascular lesions leading to RBD, in particular if it affects the brain stem. This is a rare condition, spinocerebellar atrophy type 3, but you commonly see RBD in that situation. It's just so rare, you're just unlikely to ever see spinocerebellar ataxia type 3. Multiple sclerosis can, depending if there's a lesion that affects the brain stem in a particular area, in particular the pons. Guillain-Barré has been reported to be associated with it. Sometimes mass lesions can cause that early on. Limbic encephalitis is a paraneoplastic syndrome. In other words, there's some primary cancer somewhere that generates autoantibodies that can sometimes lead to REM sleep behavior disorders. And then also withdrawal from alcohol, cocaine, or amphetamines can lead to an RBD picture, along with many, many other things, of course. So these synucleinopathies, the Parkinson family, there was a seminal paper done back in 2000 looking at 93 cases. And this was one of the early indicators that it really could be a telltale sign of what's to come. And in that, 25 patients had Parkinson's disease, and 48% of those 13 individuals, you could identify the coexistence of the Parkinson's and REM sleep behavior disorder. And oftentimes the REM behavior disorder behaviors preceded the diagnosis by several years. Carlos Schenck of University of Minnesota, along with others at that same university, were the first to identify REM sleep behavior disorder and label it, even though obviously it's been observed for several centuries. Even the first description of Parkinson's disease centuries ago involved description of individuals with fitful sleep. So it's been observed for a long time, but described more concretely by them in the early 90s. And he's followed a number of patients over the years and found that within 4 years, about a little better than a third had developed Parkinsonism. In 13 years, about 2/3 had either developed Parkinsonism or dementia. And at that same time frame, about 1/3 had remained idiopathic. So right now, it looks like even at about 12 to 15 years later after a diagnosis of REM sleep behavior disorder, somewhere between 2/3 to 3/4 will likely develop some sort of neurodegenerative disease. So, and there have been autopsy studies that looked at this and found that individuals with REM sleep behavior disorder were definitely likely to have a synucleinopathy as evidenced by the evidence on autopsy. 45% of idiopathic REM sleep behavior disorder developed a neurological disorder. In another study, anywhere from 5 to 11 years. So you can see it doesn't take long for that number to start advancing and detecting that. And also, when you break it down further based on the different types of Parkinsonism and synucleinopathies, multiple system atrophy, and there's several different types. Some involve primarily issues with autonomic dysfunction. Some can be associated with cerebellar dysfunction, so difficulties with walking or ataxia. But regardless, almost all of the multiple system atrophy patients develop RBD. And one difference here is there's no male predominance. so females with multiple system atrophy are just as likely as males to develop REM sleep behavior disorder. Dementia with Lewy bodies, the prevalence is somewhere at 50 to 80% in terms of RBD. And in Parkinson's disease, it's estimated to be anywhere from 30 to 60%. I mentioned on a slide a few minutes ago, narcolepsy is another possible secondary form of REM sleep behavior disorder. And the core of this issue is hypocretin deficiency. That's both for the REM sleep behavior disorder as well as the narcolepsy. And so that is the root pathology. And basically, we found that hypocretin is very important as a stabilizer of either your sleep or wake state. So it's kind of it's a putative flip-flop switch. So in the absence of sufficient hypocretin systems, you can flip from sleep to wake and wake to sleep commonly. That's why, not only does sleep intrude into the daytime wakefulness of narcolepsy patients, so does waking up for no clear reason during the night. That can also be commonly present in narcolepsy patients. So basically, you can get sleep conditions inserting themselves into wake. So that's why you get sleep paralysis or cataplexy, where you have the emotional trigger, and it triggers that atonia state, like you would normally only see with REM sleep. But you can also get motor tone into sleep, and thus the REM sleep behavior disorder. Some of the characteristics for narcolepsy and RBD that you see in that, well, let me rephrase that. Some of the characteristics of individuals who have REM sleep behavior disorder who also have narcolepsy, you see that it's more female. Usually there's less injurious behaviors. Commonly, these are younger individuals, and they do not have the same associated neurodegenerative association. So in other words, if you have narcolepsy, let's say you have a 25-year-old female with narcolepsy and she has REM sleep behavior disorder, she does not have a 2/3 to 3/4 likelihood of developing a different neurodegenerative disease in 15 years or so. So that's good news, for narcolepsy and REM sleep behavior disorder. It does not have that association. And treatment of the REM sleep behavior disorder for narcolepsy is similar, except for the very interesting medication sodium oxybate, brand name Xyrem, can also be used, just like it can for almost every aspect of narcolepsy, interestingly. It can also be used to help with the REM sleep behavior disorder. So, all right. So, idiopathic cases, 60% of all cases, possible prodrome for neurodegenerative diseases in quite a few. Periodic limb movements, you see that in about 70% of patients with idiopathic RBD. And you can also see an association with antidepressant use and past and present psychiatric diagnosis. And what we think is there's some mechanism by which the antidepressants can somehow release basically what inhibition you do have of those neural pathways. So it's like it's uncovering REM sleep behavior disorder down the road. Just like you see that in a lot of other conditions, just like sometimes pregnancy can cause emergent restless leg symptoms. And then after delivery, the restless legs go away. But then 10, 15 years later, then a lot more of those individuals who had it during pregnancy will have restless legs anyway. So these, it can just be one of those conditions where using an antidepressant can uncover RBD to come later. So this includes the SSRIs. So that's the vast majority of what's used. You know, your Celexa, Lexapro, Prozac, you know, all those kind of medications. But also the SNRIs like venlafaxine or Effexor, sometimes the heterocyclic antidepressants like mirtazapine, brand name Remeron, can be associated with that. Tricyclics like amitriptyline. And don't forget, this is also one of those where in an intoxication situation, or an overdose situation, you can see REM sleep behavior disorders. And then there are other things too. Interestingly, chocolate's been reported in some individuals, and then withdrawal of certain things too. And intoxication of caffeine has been reported. And I know what probably a lot of you are thinking, wait a minute, I'm intoxicated with caffeine every day. It's not your normal, you know, you drink quite a few cups of coffee. You know, usually these are people who are downing the energy drinks every few hours and things like that. Some of the findings in idiopathic RBD are olfactory deficits, and this is also, in other words, impaired sense of smell, and that's quite common also in idiopathic Parkinson's disease, but it also can be dementia with Lewy bodies, not so much multiple system atrophy. You can see slowing on the EEG before there's any presentation of any dementing illness, but you see that more in the individuals who are going to later develop dementia with Lewy bodies, and it's more consistent with the patterns that you see in that disease of any cortical slowing. And then there are also other things that you can sometimes detect on neuropsychiatric testing. And also, there's more color vision impairment in individuals with idiopathic RBD than the general population. You can also see autonomic dysfunction, incontinence, ED, constipation, those kind of issues. And they also have some different sympathetic and parasympathetic nervous system alterations. So you don't get quite as much variation. So a manifestation of the decreased autonomic activity that you can see. No difference compared to depression, with respect to depression compared to controls. And then also you can see bradykinesia or slowing of movement on a scale used to detect Parkinson's disease in some individuals. So again, possibly pointing to that neurodegenerative disease association, possibly meaning what's to come. There's some very rare RBD variants. I say that the last two especially are particularly rare. You can get a parasomnia overlap where you get RBD and then some sort of disorder of arousal like sleepwalking or sleep terrors potentially. So you can see that basically that's a motor discontrol, if you will, in both stage non-REM and REM, because the others are more stage non-REM parasomnias. Agrypnia excitata is when I say severe insomnia, it's really extreme severe insomnia, so no sleep for days, plus dream and acting behaviors. Very, very rare. I've never seen a case of that, but it does exist. And then there's status dissociatus, which I've also never seen a case of, but it's a very severe state, wake versus sleep state boundary dysregulation, very fitful sleep, and a lot of dreamlike mentation during wakefulness. Let's talk for just a minute about treatments. you'll see on this page, a lot of things are listed, but honestly, not a lot of this really is used. I mentioned earlier, it's definitely important to make sure you have a safe bedroom environment. Try and move nightstands away a bit because sometimes punches fly, and I have had people who've broken bones in their hand from punching the nightstand. But on this list, primarily what you're going to see used are the clonazepam and melatonin. Those are by far the most common and frankly the most effective, really. Sometimes if there's an associated condition, you can use the others, and we'll talk about that here in just a second. But I want to focus first on clonazepam and melatonin. Clonazepam, interestingly, does not have any effect on REM atonia, but it does reduce the behavioral manifestations and the unpleasant dream content. So it does reduce that phasic EMG activity, but it does not restore REM atonia. The usual effective dose is anywhere from 0.25 to 2 milligrams. Most commonly about 0.5 to 1 milligram will do the trick. It's effective in about 90% of cases. Of course, it being a benzodiazepine, you have to worry about excessive sedation. You want to make sure you don't use this in untreated obstructive sleep apnea because, of course, that can exacerbate, the clonazepam can exacerbate the underlying OSA. You have to be careful because this can affect balance and cause falls during the night, and certainly can have some significant cognitive effects, impairment of memory being chief among those. Melatonin has really come on strong for this, especially in the past 15 years. It really does help control the behaviors and dream disturbances. Not only does it help restore the REM atonia, but it also helps restore circadian features of stage REM. So the amount of time that an individual is in REM, as well as the REM index, so like the density of the rapid eye movements during stage REM. So it really does help restore stage REM to its proper condition. Melatonin tends to be very well tolerated. Possible side effects, and the main reason that people ever have to stop it is because in some individuals it definitely does induce nightmares. There are reports of it possibly exacerbating asthma, so just keep that in mind. I don't consider it a direct contraindication, but if I have a patient who has asthma, I just tell them, hey, if you notice that's in any way worse after starting this, then we'll probably need to stop it. Just let me know and stop it. And the usual effective dose has quite a range, anywhere from 3 to 18 milligrams. So, and it depends. And I do have people who are controlled on 3 milligrams, and I have people who are controlled on 18. So it really does depend. Some of those other medications, like I mentioned, if an individual has narcolepsy, you might want to use the sodium oxybate or Xyrem. That can be quite effective. You know, it's always nice if you can use one medication and control multiple different issues with that one medication. Periodic limb movements, if they have a lot of PLMs, there are some reports of gabapentin or pregabalin, Lyrica, helping with both conditions. So it's certainly worth a try to see. In individuals with dementia with Lewy bodies, you can try the memories that we use to help assist with memory preservation, or at least to slow the rate of memory loss, like donepezil or galantamine. I've never been hugely impressed by their effects on REM sleep behavior disorder, but again, it is a possibility and certainly worth trying. So I think we're almost out of time. Just wanted to sum up, say, you know, it's relatively uncommon, but you'll definitely see it. You'll definitely see more of it with the concentration of individuals being referred for in-lab testing, having either prominent parasomnias or severe underlying cardiac disease, those kind of situations. it is frequently undiagnosed just because people don't tend to complain about it unless it gets to that stage where they're frank injurious behavior. So, somebody who's just doing the reaching and things like that, you just don't commonly hear about that unless you ask for it. One thing to remember, it certainly can be a harbinger of neurological disease to come over the years, up to 2/3 to 3/4 likely. And the two biggest predictors that correlate with the likelihood of developing some of those neurological diseases later are the decreased sense of smell and constipation. Those are the two things that seem to lend themselves to, I shouldn't say lend themselves, that tend to be associated more with development of said conditions. But it is very treatable. That's one very good thing. About 90%, I mentioned, were successfully treated with clonazepam. And same thing for melatonin. It's around 90% or so as well. So it is a very treatable condition. So you can really help it, and potentially even get it to where some situations like where their bed partners had to move out because of the thrashing around and things like that, and you can get it to where, as long as you can be relatively assured that it is a safe situation, then perhaps they can return to the bedroom. So any questions at this point?
Dr. Talent, I'm not seeing any questions. I do see a comment, very good presentation. I learned more about RBD, especially the medication effects. Thank you.
Absolutely. Thank you.
Oh, okay. Here's a question.
Okay.
Can Klonopin be taken with melatonin? Also, if patients are still experiencing reaching out during the night, should the Klonopin be increased from 5 to 1 milligram?
Yes and yes. So, yes, you can combine those two. There's no contraindication to using both clonazepam and melatonin. I do have some individuals with particularly severe RBD where I do use both. Again, you definitely just want to make sure that, if there's any underlying sleep apnea, you've got that successfully addressed and treated. Because don't forget, if you have OSA and that's not addressed, that can be exacerbating the situation. But yes, you can combine the two. And a lot of times, instead of just ramping up clonazepam, that's something that I'll do, is try and add a little melatonin to see. It depends on, that's usually in the situation though where they come to me and they're already on clonazepam because of the benign nature of melatonin. That is my go-to. So I prefer starting with that, just because there, fewer side effects. With the clonazepam, you have to be careful about, is there any history of obstructive sleep apnea or COPD, or, are you going to induce any kind of, walking during the night and feeling more off balance or sedated the next morning, those kind of situations. So yes, you can. But if you do have, as you mentioned, a situation where somebody is on clonazepam 0.5 milligrams and they're still having the REM sleep behavior disorder actions, then I ask things like, okay, are you tolerating it well? Are you having any side effects on it? Do you have any morning holdover sedation? And if not, then yeah, in general, you can go up to the 1 milligram pretty easily, really, to make sure that you're getting better control.
All right. I'm not seeing any more questions. So again, thank you so much, Dr. Talent, for being with us again today. And
Thank
this
you.
year, hope to see you again next year, and we appreciate your participation.
My
Now,
pleasure.